Morning. Thank you for joining us today. We're going to give everyone a few minutes to settle in. For those of you who are just joining us, we're going to get started here in about a minute. Okay, welcome and thank you so much for being here with us today. We're going to go ahead and get started. My name is Lindsay Wyckoff, and I am the Director of Volunteer and Community Strategy for the American Cancer Society, and it is my absolute pleasure to welcome you to our event today. We ask that if you have multiple people listening from one line, that you please enter your names and organizations in the chat so that we have record of your attendance. Attendance for everyone else will be recorded automatically. All lines will be muted during the program, and we ask that all questions be entered through the Q&A tab on your screen. We will be taking questions during our panel discussion as time permits. If we do not have time to answer your question during the panel, we will work with the presenters to have your question answered after the event. As we get started, we would love to learn a little bit more about who's joining us today. If you could answer the poll question that's coming up on your screen and let us know which sector you represent, we would greatly appreciate it. Okay, there we go. Awesome. Thank you so much for giving us that information. We're excited to see such a diverse group joining us today. Before we start our program, we want to recognize and thank our sponsors. Without the generous support of The Ohio State University Comprehensive Cancer Center, the James Cancer Hospital, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. Now for our agenda today, we're going to start with a mission story, followed by our 4 presentations. After the presentations, our speakers will join our panel discussion, and then we will conclude with a few housekeeping items. The AAFP has reviewed navigating current issues in cancer, physical activity during cancer care, and deemed it acceptable for up to 2 enduring materials self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. The planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for this CE event other than those disclosed on this slide. Also, please know that slides will be available after the presentation, and this event is being recorded. For those of you who've joined us before, you know that we begin each session by acknowledging the individuals who are directly impacted by the topic at hand. Today, we're honored to welcome our mission speaker, Rob Oberman, whose journey reflects the power of hope, resilience, and community. Rob spent more than 200 days as a guest at the American Cancer Society Hope Lodge in Cleveland, Ohio. During his bone marrow transplant treatment in 2025. Throughout his cancer journey, Rob made movement a priority before, during, and after treatment, using it as a source of strength for both his body and spirit. Rob is a professionally trained chef and currently lives in Alaska with his wife, Patience. So, first of all, Rob, thanks for joining us, and thank you for being up extra early to be here this morning.
Yeah, thank you for having me. it's been quite the journey for sure. So let me begin by saying that my journey started the day after Christmas 2024 at 5:15 at the Alaska Blood Bank unknowingly. Stopped by to do my 40th donation to be a proud member of the 5 Gallon Club, and was told for the very first time that was not able to donate because my hematocrit was too low. I tried a couple more times over the course of the next several days. It went up 5 points and then dropped 6. So I went to see my doctor, my family doctor, uh, January of 2025. I was diagnosed with primary myelofibrosis. They said that it was aggressive. So between me and myself and my wife, we decided that we were going to go to the Cleveland Clinic. My aunt and uncle live 15 minutes from there, uh, and they're rated very high. So we decided to go there. I met my specialist, Dr. Singh, on February 4th. Uh, week Less than a week later, February 10th, he informed me that he had more bad news for me. That I actually had acute myeloid leukemia that was very aggressive. So I felt like I got hit by 10 Mack trucks. I, after getting over my uh, grief and why me and all those questions, I decided to educate myself as much as I could about the leukemia. And I also looked and researched uh, a lot of personal accounts about people's personal experiences in regards to being active and exercising and things of that nature. And so I decided that the three things that were important that was going to keep me and get me through this and keep me going was keeping my faith in God and handing all the challenges to Him in regards to anything negative or setbacks, staying positive, turning negatives into positives, and remaining active. Um, Everything that the doctors told me to be cautious about and not do, um, I researched, talked to Dr. Singh about, and I was able to stay active. And that was the best thing for me. Um, Going out and um, doing brisk walking and then normal walking, inter doing it in intervals helped me tremendously, and it helps distract the mind, uh, helps helps you immensely in regards to staying positive, and changing your scenery is so important. There were so many fellow patients that I met that were not active or stayed at the Hope Lodge, did not go or leave. They were capable of it, um, but for whatever personal reasons, they chose not to. There was a few of them after they saw how I was reacting and how active I was. They actually followed my lead and decided to start being active and going out for walks and changing their scenery. So that I was happy to see that. It I don't know how much I can emphasize that um, the negative things that you hear and the things that you're told by your caregivers or other uh, professionals, you have to kind of take with a grain of salt and listen to your own body and like I said, just stay positive. That's the most important thing is just staying positive and keep moving. I mean, after I got my Hickman put in, which I learned a lot about. I went to the doctor that actually put it in and talked to him about it and asked him, hey, after a period of time, a week, 2 weeks, whatever, can I get back to doing push ups? Can I get back to doing upper body exercises? And he said, absolutely. Where some of my other healthcare providers had suggested that I don't because they didn't want me to disturb anything. Well, he talked to me and he said, no, you're going to be fine. After 2 weeks, you're going to be healed and you'll be fine. Just don't try to be doing, 200 push-ups. So I was able to get back to doing push-ups. I was able to do upper body exercises as well as doing my walking. And I made it a goal of mine to be as well fit as possible going into my transplant, because everything I read was about, the more fit you are, the easier your recovery is going to be and the less time that you're going to be down. And so I was able to do that and prove even to my uh, primary uh, nurse that was true, because she kept telling me, well, you're going to be down for 5 to 8 days after, the heavy doses of Cytoxin that you got and everything else, and your neutrophils go down and everything gets wiped. You're going to be down. And I kept telling her, no, I'm not. No, I'm not. And every day she's like, I can't believe you're telling me that that's not going to happen. And I'm like, I'm me. You're speaking from your own experiences. I'm speaking for myself. I'm not going to speak any of that into existence. And so it was true. I was down. I was down. I couldn't lift my head off the pillow. My wife had to feed me applesauce and jello. I couldn't even lift a fork. It was horrible. But then the next day, midday, I actually got up out of bed and walked over 2,000 steps. And every day after that, it just increased. And my doctors and fellow caregivers were amazed. They're like, wow, Rob, I can't believe that you're already up and moving. And I did. And when you're a BMT patient, you can't leave the floor. So I had the BMT wing and the leukemia wing to walk. I was admitted on May 30th and was allowed to leave on June 19th. From May 30th to June 18th, I walked 162.2 miles between those two wings. And doing that, it helped other patients. My doctors would tell me, yeah, they asked me who that guy is that keeps walking by the room. And so it actually helped other patients to get out and move. So I was, really happy about that. And it motivated me even more. Um, and I love sharing my journey, which I'm still on. Things are going well. I've had a little bit of GVHD, but very minimal. And things are going very well. My blood counts have been in the normal range for the first time since some point in 2024 for 3 consecutive months, and they've been doing well. So happy to be here.
Rob, thank you so much for sharing your story. This is the second time I've heard you share it, and it just blows me away every time. And we're so grateful that our paths in Ohio crossed with you as you stayed at our Hope Lodge. So thank you so much again for the really early wake up this morning to join us here today.
Oh, thank you, Lindsay. I appreciate it.
Take care and keep on getting those steps in.
Yep, absolutely.
As I mentioned, I've heard Rob's story before, and he's the perfect person to join us today, as I just picture him walking all around Cleveland. We are very excited to share our first presenter today will be Dr. Catherine Schmitz. Dr. Schmitz is Deputy Director of the UMPC Hillman Cancer Center, a professor of hematology oncology at the University of Pittsburgh School of Medicine, and a former president of the American College of Sports Medicine. An international thought leader in exercise oncology, she founded and leads the International Society of Exercise Oncology and ACSM's Moving Through Cancer initiative. And she authored the first ACSM Exercise and Cancer Guidelines and also served as senior author on the second, earning numerous honors, including the President's Council on Sports Fitness and Nutrition Lifetime Impact Award. Dr. Schmitz, thank you for being with us today, and I'll turn it over to you.
Right, fantastic. Thank you very much. That was really a wonderful, wonderful story, Rob. Thank you so much for sharing with us. Patients like you are the reason why I wrote the book, Moving Through Cancer, seen on this slide. It was intended to take the evidence base that we have in exercise oncology and hand it to patients from the point of diagnosis through the balance of life. And meet people where they are. Not everybody is Rob Overman. He's a very special guy. There are people who are a little more resistant to exercise than that, and so we really do need to meet people right where they are. I'll also note that for those of you that are professionals in the field of cancer who are interested in more information about exercise oncology, there is a textbook now from the American College of Sports Medicine called Essentials of Exercise Oncology that I co-led with Anna Schwartz and Anna Campbell, that's available now. You can find it on Amazon. Next slide. So I want to start with a little history lesson. This, as you see on your screen, is the advice that was given to breast cancer patients in the 1950s if they were treated at Memorial Sloan Kettering Cancer Center. And what you can see is that all women wore A-line skirts at the time, of course. And you can see that, post mastectomy, women were advised to do wall crawls. That's not that different now. Something to do with a cane. I'm not entirely sure what the little circly thing with the string is, but then I'm pretty sure it's the Macarena that she's doing down here in the bottom right. And then, of course, the squiggly lines denote that she's swimming. So this is a handout that was given to all patients post mastectomy at Memorial Sloan Kettering. So just click one time, and I think something's going to appear on the slide. Yep. So you can't really read what's underneath that swimmer there. So I blew it up for you. Swimming allows maximal use of the affected arm. These motions train the deltoid and other muscles to carry on the function of the lost pectoral muscle. And this is just to denote how very, very far we've come. At the time that this handout was given to women, the common surgery that was done for breast cancer was called the Halsted procedure, which took not only the whole breast, but all of the muscles underneath it and into the armpit so that the arm would kind of hang fairly useless on the affected side. And so the idea was, well, maybe swimming will help with that. So we really, truly have come a very long way since the 1950s in exercise and breast cancer. There has been an enormous proliferation of randomized controlled trials in the field of exercise oncology. 80% of those trials have been carried out in breast cancer patients. And there's a couple of things to note on this slide. One is there really was very little research at all back in 1990. First human clinical trials that occurred in this field were in the late 1980s, carried out by Whittingham and McVicker, two nursing scientists at The Ohio State University. And then our first ACSM roundtable occurred in 2009, published in 2010. And that spurred an exponential growth in the number of randomized controlled trials till we had our second roundtable in 2018. And that exponential rise just continues. If you were to go into PubMed and search for randomized controlled trials on exercise and cancer and isolate it to randomized controlled trials in the English language, you get over 3,000 hits now. And so, not surprisingly, we think we can conclude a few things. Next slide. So the documented symptom benefits of exercise during and after cancer treatment include fatigue, sleep, quality of life, anxiety, depression, body composition, physical function, and largely due to my own work, breast cancer-related lymphedema. It used to be that women were told never to lift anything heavier than 5 to 15 pounds ever again in their lives. But because of trials like the PAL trial, which I led, and the resulting Strength After Breast Cancer program, we now tell women that they should be doing slowly progressive resistance exercise for their upper bodies after breast cancer. We've come a very long way. Next slide. There was also some extremely exciting set of findings that just came out just slightly less than a year ago from the Challenge trial. And the Challenge trial recruited nearly 900 colon cancer patients, average age 61 years, balance of men and women, and randomized them to a structured exercise program compared over 3 years compared to a health education materials alone program. And if you click one more time, there it is. The disease-free survival outcome, which was the primary outcome, showed a 28% improvement in disease-free survival. Now, while it's not on this slide, I'll tell you that there was also a 37% improvement in overall survival. This is the first randomized controlled trial to show us that exercise has a survival benefit, and it has turned the field upside down. Everybody's scrambling to try to figure out how to make exercise standard of care for all of their patients now, not just colon cancer. Next slide. So one of the things that we responded to the Challenge trial with was a commentary that was called, if exercise were a pill, we'd all prescribe it to patients with cancer, but it's not. And so I will just give you this thought exercise. If today we were to start to prescribe chemotherapy the way that we prescribe exercise, how do you think it would go? So what I mean by that is we would tell patients, I'd like you to go get some anthracycline. I'd like you to do a bone marrow transplant. I'd like you to get some cisplatin. There wouldn't be no chemo infusion suite. There would be no ports placed. There would be no staff to help people. There would be no big chairs to sit in. There would be no pumps sitting by those chairs. There would be no wandering dogs, their therapy dogs, or warm blankets or snacks. There would be no chemo nurses, no chemo pharmacists. There would be none of that infrastructure. We would simply tell people to go get their chemotherapy. What proportion of people who needed the chemotherapy do you think would actually get it? Not many, right? So if we believe, based on the Challenge trial, that exercise is truly therapeutic, then we're going to need to build an infrastructure. That infrastructure is going to need to include programs that are very well codified. We can't decide that it's going to be pink Pilates and yoga over here and something else. It's going to be more like cardiac rehabilitation. It's going to be a codified program. We need to learn how to decide who is ready to do those programs, who needs to see a physical therapist, and who can be released to go walk with Rob. We need accreditation and policy changes in order to make it a mandate that it would be standard of care and it would actually be against medical practice not to be prescribing exercise and providing the infrastructure for it. And finally, we need economic analyses in order to show that there is a return on investment for health systems that provide exercise oncology. Next slide. I just want to say thank you to inviting me to be a part of this excellent forum today. And I'll finish with one last slide to invite everybody listening to join me. You'll go just to the last slide. I hope there's a last slide. There it is. I'm hoping everybody will join me in Heidelberg, Germany in July this year for the first inaugural conference of the International Society of Exercise Oncology. We have over 300 abstracts that have been accepted. This is going to be a much larger meeting than we originally thought it was going to be. And we're very excited to welcome you. Thank you so much for your attention.
Thank you so much, Dr. Schmitz. I can't get over that first imagery you shared of what was prescribed to patients. It's amazing how far we've come, and thank you so much for your work in that. And that conference sounds so exciting. Our next presenter is Karen Hawk. Karen is an Ohio State University trained physical therapist with a master's degree and a Lymphology Association of North America certified lymphedema therapist since 2005. She has served in leadership roles at Atlanta and service on the NCCN Survivorship Committee for Lymphedema. She has dedicated more than 35 years to oncology rehabilitation and is currently Associate Director of the James Ambulatory Oncology Rehabilitation Department at The Ohio State University Wexner Medical Center, James Cancer Hospital, and Solov Research Institute. Welcome, Karen. Thanks for being here today.
Thank you, Lindsay. And if you can say our title of our institution like that, great. Thank you, Rob, for a wonderful story. And what I'll present to you today is what we're doing here at the James, some of what we're doing at the James. And that comes on the back of the work done by wonderful researchers and people like Dr. Schmitz and Dr. Stout and many others. So I appreciate that. And I had the honor of also working with Dr. Whittingham and Dr. McVicker that you mentioned, who started a lot of what we're talking about today. What you see is pretty much the framework of how we've laid out our program here at the James. We think about exercise or activity as critical for all of our patients at any point in their cancer journey, and we've laid this out on the Dietz Oncology Rehab model of care. Along with that, we know that survivorship starts at the time of diagnosis, so we want to try and be as proactive as we can versus reactive to what our patients are going through. Our programming framework is helpful, but treatment plan of care needs to be individualized to our patient, to their treatment, their anticipated treatments, and their comorbidities. We know that people do not enter our cancer journey without perhaps other diseases, injuries, even if they're a young AYA cancer survivor. I'll give you my favorite quote now because it kind of is what I'm always thinking about as we talk about programming. It was from Jim Kelly. Make a difference today for someone facing or fighting for tomorrow. So that's kind of what we think about. So as we plan our clinical practice guidelines, we lay this out on the framework of the Dietz model, and we are looking at a continuum of care as our patients move through their treatments into longer-term survivorship, into palliation, if that is a part of their care, and how can we incorporate rehab, activity, movement into those programs to help them reach their goals. One example of one of our practice guidelines happens to be our bone marrow transplant guideline. And just one piece to call out is we're really trying to look at our outcomes. What can we use to get a good baseline for patients? What can we use to follow them across the continuum? Are we getting them back to their baseline or better than their baseline? Are they meeting their age-related norms? One of my soapboxes is just because someone is maybe a younger cancer patient and they can walk into the clinic on their own and the eye test tells you that, oh, maybe they're okay. We need to make sure that they're functioning at the level of a peer who doesn't have cancer. So how do we look past chronological age? Another thing, with our guidelines, we're proud of what we've done, but we have ways to go. We need to start incorporating more of our other partners into our plan of care. On the next couple slides, I just highlighted some of the programming that we have in each of the areas of our framework. one of the pieces that we're really trying to build on is the screening piece, and the NAPBC really helped with that, as they had a standard for functional screening for new breast cancer patients. So that's really been helpful, and our nurses do that, and then we'll refer to rehab. We've bolstered our pretreatment for a lot of different disease lines. And as we look at active treatment, that's where folks probably most often think of rehab. And we have many programs in that space as well. And we know that patients can benefit from rehab during their active treatment, and that's important. One program that we use a lot, our James exercise program, is really for any point in the patient's care. My dream, I don't know if I'll see it, but I hope to see it in my lifetime, is that as a patient is diagnosed, they're also screened or assessed for physical function, so that they're followed throughout their plan of care, and not just at pieces or parts along the way. So our James exercise program can be at any point in the plan of care, and we hope that we're using that to help patients get back to how they want to exercise as they're exiting their active treatment. So we use that to move them along in their plan of care. We also have a multidisciplinary palliative clinic, and we'll be expanding that service as well in July as the inpatient unit opens. As I finish up, I just wanted to highlight our James Care for Life programs. These programs are, I'll let you go to the next slide for me. These programs are to empower patients in all aspects of their care and survivorship, and it's for caregivers as well. I'll focus a little bit on our movement program. So on the next slide, there's some of the classes that are provided. They are free to patients and caregivers. They are hybrid for the most part, so they can participate virtually. And this gives us the ability to really transition them from maybe an active rehab program into a supervised exercise platform. They can try various things and maybe find something that really speaks to them. And on the last slide are just some contact information for some of those programs. So I really appreciate the opportunity to speak today, and thank the American Cancer Society for that opportunity.
Karen, we're so lucky to have you. Thank you so much for being here. At ACS, we talk a lot about the cancer continuum, and survivorship is a big part of that. So getting people to where they want to be exercise-wise is so meaningful. So thank you so much for sharing all that great information. Presenting next is Jody Deisler. Jody is the Revital Oncology Rehabilitation Director. She has been treating physical therapist for over 30 years and has been working in oncology rehabilitation over the last 10 years. The Revital mission is to make cancer rehab the standard of care, so everyone impacted by cancer has access to rehab services. Thank you so much for joining us, Jody. Jody, we're excited to hear from you.
Great. Hi. Yes, my name is Jody, and I'm really excited to be here because exercise is my favorite thing to talk about, and especially exercise through the cancer continuum. All right. So first thing I wanted to talk about was the difference between exercise versus physical activity. And I bring this up because this is something I talk to all of my patients about. Any new patient that comes in, I like to ask, what's your normal exercise program? And probably the most common thing I hear is, well, I walk my dog a couple times a week, or maybe I work as a teacher, so I'm up on my feet a lot of the day. But the truth is, we need both structured exercise and physical activity. And usually what they're describing is physical activity. So I want to define them just because I think it's important. Physical activity refers to any bodily movement produced by skeletal muscles that requires energy expenditure. It can include things like taking your dog a walk, household chores, gardening, and occupational tasks. And it's really important for our general health, for improved circulation, all of those things, but it might not be specific enough to elicit physiological adaptations. Exercise is more of a structured, planned, repetitive form of physical activity designed to improve or maintain physical fitness, strength, endurance, or flexibility. It's designed to induce specific physiological changes like increased cardiorespiratory fitness, muscle strength, or improved metabolic efficiency. And this is what's key. These benefits are particularly relevant in oncology, where structured exercise can help counteract treatment side effects like fatigue, muscle loss, and reduced functional capacity. So important for us to have both in our lives. So, after I talk to my patients about, what kind of exercise activity you're doing, the next question is, well, how much do I do and how do I know how much to do? Because commonly patients are told, you need to stay active, but don't overdo it. And that can be kind of confusing. So ACSM has come out with recommendations of 150 minutes a week of aerobic and a couple days a week of strength training, maybe a little bit less than that if they're in active treatment. But that could be a little daunting to hear for someone who is a sedentary lifestyle or is maybe in the middle of treatment. So I think the important thing on this slide to remember is you don't have to start at 150 minutes. In fact, last week I had somebody that I started at 2 times a week for 5 minutes marching in place. It doesn't matter where we start as long as we move up. You can believe we're going to work towards the 150, but finding and meeting patients where they're at, wherever that is. If that's 2 times a week for 5 minutes, that's where we start and we move up from there. Now, Commission on Cancer and APBC, NCCN have certainly come out with guidelines that emphasize that providers should play an active role in referring patients to appropriate exercise interventions. So it's good we have these entities coming out, really making that stance. But one thing that can be a little confusing is sometimes oncology, rehab, and exercise those terms are used interchangeably. So we need to make sure that there's a clear understanding of when patients need to come to oncology rehab versus a community-based exercise program. So when we think about oncology rehab, this is sort of a laundry list of things we might see in oncology rehab. And, most people think of lymphedema when they think of oncology rehab, but the truth is the most common thing we see in the clinic is cancer-related fatigue. And any of these things we might see in the clinic, from just general range of motion and strength issues to pelvic floor issues to cognitive rehab issues. They're all certainly seen in the clinic. But what can be a little different in oncology care is many times we're seeing patients before their first event, whether that's surgery or chemotherapy, to really optimize them for that event. And then we're seeing them really throughout the cancer continuum because we know what's coming. They might be doing just fine right after surgery, but if we know radiation is coming or we know chemotherapy is coming, we need to prepare them for that. I always like to say, the year or two of cancer treatment is sort of like a marathon. And the stronger we can get you moving into that, the better you're going to be able to tolerate all of those things. So a lot of providers will ask me, well, how do I know when I need to send somebody to oncology rehab? And there's lots of different ways to know, but this is just one example that many of you have probably seen. It's the distress thermometer, and NCCN has come out with when we should refer for oncology rehab, and all those things highlighted. If you score more than a 4 would be a reason to do that. And the last slide I have is really the most important, and it's really that good communication is key. When I talk to providers, I like to ask, what impairments do you see that your patients are having? And, is that something we can help with? And if it is, then we really need to set up a protocol and a way for those patients to get to us. So it's not just when a provider remembers, but every patient that they think is important gets to us. And then the bottom part is the last thing I want to touch on. Oncology rehab and wellness can happen concurrently, and you need to have a really good relationship with your wellness facility so that you know when you need to refer back and forth. With Ohio Health, we have our Wolf Wellness Center, and that's, we have programs where we know how to refer back and forth, and we do that all the time. And last is just my contact information. And I guess my last take-home point is just that, exercise can certainly be fun, but most important in oncology care, it can be really empowering to patients. Cancer can be, something that's really a lot out of your control, and exercise is really a way to put that back into control so you know how to handle your symptoms, you know what to do next to prepare you. And thank you for having me.
Jody, thank you so much. That was so helpful. And I don't know, it made me think of my friend who just beat breast cancer, and the fatigue was so real. She's an Energizer bunny, but surgery and everything wiped her out. And she's now back to where she was exercise wise. But that is so important for patients. So thank you again for being here. Our final presenter is one of my favorite people to listen to at ACS, Dr. Nicole Stout. She is the Senior Director of Survivorship and Wellness at ACS and an internationally recognized leader in cancer survivorship research and care delivery. With more than 25 years of experience, she has advanced survivorship guidelines and scientific consensus, published extensively, lectured worldwide, and serves as an adjunct research faculty at the West Virginia University Cancer Institute. Dr. Stout, it's so good to see you and looking forward to hearing from you.
Well, thanks so much, Lindsay, for those really kind words. And thanks to all of the panelists before me. You could not have just laid this framework in a better way for me to talk about what I'm going to talk about next, which is how do we encourage getting this into the clinic spaces or the community spaces where cancer survivors live and work and participate in their daily roles. So my role at the American Cancer Society is as the Senior Director for Survivorship, and my portfolio is looking across elements like exercise rehabilitation and thinking about how do we do a better job of embedding and integrating these very important interventions into the cancer care delivery systems. I will tell you, I have a long-standing history of working with Dr. Schmitz and Karen, and I'm thrilled to be on this panel. So thank you. Some of the key points that I want to just plant in your mind when we think about having these services available as a standard. We've heard that the importance is high, and this is not a nice to have anymore. And I would suggest, and I say this in public forum, the evidence is too strong around exercise and rehabilitation for us to not incorporate this into the cancer care continuum. In fact, there's such a preponderance of exercise and the outcomes that it demonstrates that we have to wonder if we are not being negligent by ignoring the implementation and integration of exercise and rehabilitation to enhance our patients' functioning and their outcomes. So some key points that I want to plant in your mind as we talk through just these next few minutes of the how do we get there. We have got to stop thinking about a referral-based system that treats exercise and rehabilitation as downstream care. So the let's see how you do getting through treatment is not the phrase that we want to hear coming out of a provider's mouth. What we want to think about this upstream at the point of diagnosis, understanding what type of interventions are indicated, are needed, and are most helpful. We then think about embedding that assessment for exercise prescription at the point of diagnosis for every patient. Everybody needs something, right? And that something will change over the course of their cancer treatments. So therefore, we've got to build a system level pathway that is applied consistently. All patients, not reactive referrals, but a pathway that an individual follows along in a prospective manner where we repeatedly assess, identify when meaningful changes happen, and decide how do we adapt an exercise program, how do we tailor it, and or how do we then refer that individual maybe to a specialist for rehabilitation. I love Jody's recent comment, which is, working closely with your wellness, the exercise professionals and physical therapists together. I think it's critical. There are times when one service is the most appropriate, but sometimes you need that extra rehab to get them over the hump so that they can continue with the exercise that they need. And we have to think about designing this for equity, but also for scale. So I'm going to touch on each of these. Next slide, please. The evolution of cancer survivorship, we all have said, and we say the words for years, survivorship starts at the point of diagnosis. And then in the very next sentence, we say something like, well, when a patient's done with treatment and may move into survivorship. And that is not, we need to retract those statements, and we need to think about this continuous state, because that's what survivorship is. I think of the essence of survivorship as really someone being able to participate in the daily activities that they want to participate in every day, regardless of their cancer diagnosis, regardless of the severity of their disease, and regardless of where they are in that continuum of care. So the essence is being able to participate and do the things that you want to do. In essence, survive and live life. But our current gap puts us in this reactive care versus a proactive approach. You can click. So I really think, click again, what we need is really more of a revolution in the way that we talk about, but also in the way that we enact survivorship care. So the idea that it is a continuous state, that it is the individual moves through and evolves through these different phases of treatment. And throughout the duration of that time, we walk alongside them, understanding what needs arise. When they do, we're there to be able to give them the appropriate guidance to get them to the right person at the right time. Next slide. And so when I think about a recent paper that I wrote, which is still, it's coming as a part of a special issue in the Journal of Cancer Rehabilitation, asked me to speak about rehabilitation integrated survivorship. And I think about this not as a service line, but as a system of care, an ecosystem that needs to exist, really a life cycle model of optimizing somebody's ability to participate in those life roles that we talked about. And starting at diagnosis, and I think this continuum follows what Jody showed you, what Karen showed you, and what Katie showed you. So we're really speaking the same language. Starting at diagnosis, optimizing the individual's ability to perform, and monitoring them throughout the duration of treatment, post-treatment, and really for the duration of their life. And I'll say this again, everyone needs something. And even at the point of diagnosis, right? Let's think about the spectrum of individuals, human beings. Some of them may be incredibly well-fit, conditioned athletes. Guess what? At the point of diagnosis, they still need guidance on how to stay fit. What is safe for them to do? What is an optimal prescription for that individual? On the other end of the spectrum, an individual may never have exercised or doesn't see that as an important goal, but they definitely have needs to understand how to keep moving and how to keep active during cancer treatments. So those needs, we think of that entire spectrum, very well conditioned, someone who's never an exerciser. Everyone needs something, and everyone in between needs something. And we've got to be able to tailor the recommendations and the interventions to those individuals. So across that entire spectrum, we're thinking, what's the right intervention? What are the right words for me to use to position this to get buy-in from this individual? How do I create motivational strategies to engage this individual? So this is more, and we have to think beyond. This is more than just handing them a brochure. As my good friend Dr. Schmidt says, brochure therapy does not work. We use brochures as a control condition in many of our studies, and the studies continue to show superiority of supervised exercise programs, one-on-one or group therapy interventions at helping to improve function and improve outcomes. Now, I like to think about this from a whole person care perspective as well. So the exercise component, where is my nutrition, education, and guidance? How do we think about the cognitive support and the psychosocial care, really? So all of those elements of whole person care that need to come together along this continuum. Next slide. So, and kudos to Dr. Schmitz for the amazing work that she has done corralling the American College of Sports Medicine and the Moving Through Cancer Initiative, the roundtable guidelines that were produced, the articles that followed on that, and really starting to push the conversation about exercise implementation pathways. How do we do this, right? What does the workflow look like? Who does what when across that the clinic workflow to understand the individual's baseline function? How do we assess? What are the tools that we need to use? What are the clinic resources that we have in place? How do we embed that into our electronic health records and into our staff knowledge base and work? Once we understand someone's baseline function, right, where they are on that spectrum, We can then come up with a risk stratified approach. Some folks may be highly motivated. Maybe we touch base with them in an ongoing fashion once a month, once every 3 months. Others may have greater needs for more intensive interventions. So we sort of stratify risk. Who needs what when? A guided program, light touch, heavier touch, or more intensive rehabilitation. And a key point then comes next, which is the ongoing monitoring. So I think about this as a closed loop system. We can't just say one and done. Here's your exercise program, Mr. Smith. You've just finished chemotherapy. You're very deconditioned. I'm going to give you this exercise program. We've got to follow him in 3 months, in 6 months, because he changes over that course of time. So the individual that we see at the start of chemo is a different person and has different needs in 3 weeks or in 6 weeks as they're into cycle 3 or cycle 4. And as they move into radiation and as they move through immunotherapy, sometimes for over a year, that individual changes, and that necessitates an adaptation to those recommended exercise interventions. Well, what comes next for Mr. Smith? It depends on what we identify in our ongoing monitoring strategy. So we've got to find very simple ways, but efficient ways to continuously monitor individuals' functional measures, understanding how they're adhering to their program, perhaps using patient-reported outcomes, patient feedback mechanisms, and our clinical tools to identify when meaningful change occurs. Deconditioning and fatigue, neuropathy, falls, balance challenges, cognitive changes, all of those may warrant change in the exercise program and perhaps the referral to rehabilitation. So what are those escalation triggers that we need to think about? And that entire loop continues as we go. So really this is what is the right intervention at the right time to help to optimize that individual's function. Next slide. And so our future action here is to think about this more as an ecosystem rather than just a single provider making a recommendation. Maybe you have a physician champion. Exercise is good. Yes, we want people to exercise. But the challenges are, how do we create that ecosystem in our healthcare systems and in our communities so that we're conducting those assessments? Our clinician workflows are consistent with asking the right questions, providing the right information at the right time, and connecting patients with the right resources, either in our cancer centers or in our communities. Digital enhancements have arrived and are being used very robustly in the exercise and rehabilitation space and in survivorship. This can be telehealth engagement. We're seeing a lot of interesting findings in the remote monitoring space. Some of that is just patients filling out a questionnaire of symptoms and identifying levels of symptom change and symptom toxicity levels, which then trigger decision support. Some of the app-based environment has exploded with cancer exercise apps and cancer exercise and cancer support and survivorship support apps that help to provide individuals with the information they need to optimize function. And we're also even seeing virtual coaching and AI-guided support come into the mix. And so we've got to make sure that these are evidence-informed and appropriate tools. I will say this about equity. Equity is far more than access. I think we think about the haves and the have-nots, and well, if we just had better coverage for the services, if we just had better insurance, and if we just had more exercise professionals, if we just had more physical therapists, everyone understanding exercise oncology. And yes, that will help to promote access, but we also have to think about ways to engage the individual. How can we be sensitive and appropriate in the way that we communicate? Exercise is not a word that some people are familiar with. It's not a part of their lexicon nor their lifestyle. How do we find ways to engage them around movement strategies, being more active, being able to do the things you love to do more because you move more? So our communication strategies will lead to better buy-in and better participation. We also have to think about the social determinants and how those influence individuals. People may very much want to participate in an exercise program or on their own or in a group. But perhaps, they work multiple jobs. They're of a lower socioeconomic status and don't have the funds to pay 99 cents for an app registration each month. So we really have to think about the totality of those social determinants and how those behavioral factors, social factors, financial factors also influence the delivery of the programs that we provide. Next slide. So when I think about our future direction, a next generation survivorship model is exactly this continuous and adaptive system. So taking the exercise rehabilitation piece of this and leveling it up. This is what we're looking at as a survivorship approach, largely and broadly at the American Cancer Society, and a message as we move forward across the nation. We need to bring together the technology, the data, whole person care approaches so that we can optimize function throughout the cancer continuum and really throughout the lifespan. Using this model of continuous engagement, real-time data and insights, helping to use that to personalize the interventions to get us to the outcomes that matter. So this connected ecosystem is really the approach that I'm thinking about. How do we leverage the tools, the resources, and the staff so that we can get to that proactive, personalized, and really empowering approach to help individuals move more, move better, and optimally live the life that they want to live with or beyond cancer. Thank you.
Thank you so much, Dr. Stout. I really love all of the things that you shared, but I think one of the most important pieces was tying it back to equity and meeting people where they are. And all of these programs are so great, but if there isn't equitable access to them, they're not reaching everyone. So I really appreciate that perspective. We've heard amazing perspectives today on the importance of physical activity during cancer care and how activity recommendations can be incorporated into that care. So we're now going to bring back all of our presenters to discuss these ideas, where they align, where they differ, and how to put them into action. So please join me in welcoming back our presenters. We're going to start off with a few of audience questions. So if you continue to have ideas as we go through the panel, feel free to pop them in the Q&A chat or box. And I think where we'll start is this is open to everybody, but it was definitely directed to Karen. When you talk about having patients complete exercise regimens alongside treatments, are there tactics or actions you've taken to ensure that uptake and completions of those plans?
Thanks for the question. I think it's been said already this morning, but we meet them where they are, and I think looking at setting those goals that mean something to them and something that they can achieve. And then once they achieve those goals, really celebrating that. So I liked Jody's example of 5 minutes, maybe twice a week, but really finding something doable that has meaning for them. And I like sometimes to incorporate maybe family in that. So if they're going to walk, that's great. Maybe they can walk with their child and they can review spelling words while they walk, or play basketball in the driveway with their children. And if you play pig, you can practice spelling too. So you can accomplish a couple different things.
I love that. Does anyone else? I was going to say, please jump in with other answers too, of course.
Well, I was going to ask Katie to speak to, in the spirit of meeting patients where they are at. Do you want to talk a little bit, Dr. Schmitz, about your roving exercise engagement in the chemotherapy suite and how you use that at the University of Pittsburgh to get in front of individuals, literally meeting them where they're at and having these conversations?
Sure. So at Hillman Cancer Center, and 3 different locations, actually, in the Shadyside location in Pittsburgh, but also in Newcastle and in Erie, Pennsylvania, we have a triage and referral system for exercise oncology that starts with the Exceeds triage system that tells us who needs to be seen by oncology rehabilitation, and then we make those referrals. And who is ready for a home-based structured exercise program that we can build for them and monitor them. And we're experimenting with exactly how much monitoring they need, which is a fun quality improvement project. And who's ready to go walking with Rob? Who's ready to be on their own? Because there are some who are really ready to be on their own. But what we've actually found, and I'm sure that everyone here is going to nod vigorously when I say this, is we actually have found that there is a second layer of triage that we do that I think is implicit in everything everybody here has been doing, but we've tried to make it explicit, and that is we call it a behavioral retriage. And we're recognizing we have 3 levels. We call them willing, wobbly, and no way. So these are the patients we walk up to who we, tell them about what we're there for and that we want to help them with a home exercise program. And they say, where have you been all my life? And oh my gosh, this is great. I can't wait to use these resistance bands you're giving me. Oh, wait, let me understand this a little bit better, and they're very enthusiastic. And then at the opposite end are the people who tell us to talk to the hand. No, I'm not, I'm not doing it. And, we give them chair stands. We still give them one exercise. And then in the middle, we do a little bit. So we're meeting people where they are, not just according to a clinical triage that tells us whether the person has neuropathy or whether there's a stoma or whatever other issues might be present that are important, but we're also meeting them where they are in terms of their behavioral readiness to approach physical activity or exercise. And by the way, when we do the retriage, about 40% of people are retriaged into a different group according to when we do not just exceeds, but also behavioral.
And that is really meeting them where they're at and meeting the needs, right? It's so easy to just blanket prescription or blanket recommend without really understanding some of those behavioral or contextual factors that are drivers for these individuals or demotivators. So I think that the demotivation is a barrier. I'm afraid because of treatment. I'm tired because of treatment. Those each require different I've never exercised, right? Like I said, everyone needs something, but that something needs to be personalized, tailored, and then it changes. Lindsay, I know you have some more questions.
Yeah, absolutely. One of our attendees wants to know about the PT programs that were talked about. Are they provided at no cost to all cancer patients? And if they're not, how do you ensure these programs are made available to all patients, particularly if cost is a barrier?
I can speak to, are we referencing the programs outside of rehab or?
That's a great question. It says all PT programs, so probably any of the ones that were discussed today.
I know one of the barriers we continue to have is what insurance will let us do. So really trying to continue to lobby and do what we can to improve insurance coverage for our patients. A lot of our James Care for Life programs we do offer for free, basically, so there is access for patients, though even a virtual program, if you don't have the ability to connect that way, it is a limitation. So continuing to work on ways to make all of that very accessible.
Yeah, at Hillman, we have a combination of things happening, and I have one extremely exciting announcement. The majority are of staff who are doing our exercise oncology and oncology referral work are paid for by philanthropy. And so our Erie program is from the Hammett Foundation, and the Hillman Foundation pays for things in both Newcastle as well as in Pittsburgh. But as of March of 2026, the UPMC Executive Committee has voted to make exercise oncology a covered benefit for breast cancer patients for UPMC employees, which is the first step towards making it system-wide. And I have a meeting today at the big old steel tower to start talking about designing this benefit. And it's going to go live January 2027, I believe this makes UPMC the first payer in the United States to make exercise oncology a covered benefit. So
Wow.
one
Wow.
has fallen.
That's
One has fallen, and there was a lot of advocacy. So a lot of what's fascinating, Nicole. I will tell you what was fascinating was what was it? What was it that tipped the balance? Like what slide deck would you make to go in front of the executive committee? The slide deck that won is not the slide deck that you would make. So it was sort of fascinating.
interesting. But these barriers around cost, right, and reimbursement and reimbursable codes and services, I think it really, again, we have to think about an ecosystem.
Right.
And it isn't just a person sometimes. Is there an app? Can we do a digital engagement? Is it the physical therapist? Sometimes we get 5 visits and we can use those over a month. The pre-authorization might be a barrier. There's a $50 out-of-pocket copay, right? So all of that kind of stacks up. And this is all the more reason that we need exercise professionals, PT, rehab, and this digital environment to work together and find that symbiosis where I can say, I can have you see an exercise professional who's a cancer exercise specialist in our wellness center. We have a sliding scale for payment, for a monthly payment. Much of that is free based on income. And I can work in tandem with them to say, patient's doing great, they're moving more, they're gaining strength, they're gaining endurance. But you know what? There's this little bit of a balancing that's come up now that they are on, a platinum-based therapy. And so they kick them back to the rehab provider for a couple of visits. So that kind of symbiosis, I think, is what we need more of. And I think having the EPs as a paid service, exercise as a paid service, really helps us with that triage and staging system. Because if we say we need a triage system and our administrators in medicine go, yeah, that's what we need. Well, guess what? Level 1 and 2 of that triage system don't get paid. Level 3, well, maybe there's all these barriers and level 4 does. That isn't going to fly. So we really have to think about that holistic approach, making sure that we bring the right services based on the intensity of the needs of the patient. So I love that you're doing that, Katie. That's amazing.
Mhm.
I
Very
think it's important too, just to get out the message that like oncology rehab is a covered service by insurance. I have always said, as I've talked about oncology rehab, there's sort of two things I hear most. And one is, what is oncology rehab? Because everyone knows what physical therapy is, but they don't, well, what's oncology rehab? Are you giving me a shot? Is there a needle involved? It can be a little confusing. So that's number one, something I hear. But the number two thing I hear all the time from physicians and all across the board is, but is this covered by insurance? So we just need to get that basic fact out. Of course, we need more insurances, in network and all those things, but it is a covered service. And most of our wellness programs do have, scholarships, things like that, that if there is a financial need, we usually don't turn people we want people to be in those programs. So if there's a will, there's a way.
No, that's great to know. I personally did not know that. So I think that is an awareness issue for sure. Switching gears a little bit and talking about kind of the data behind the work that you all are doing, what specific research is there or is there any that's showing that exercise increases longevity for cancer patients?
Oh, yeah. So the strongest evidence that we have in the canon is from the Challenge trial, which recruited 889 colon cancer patients and randomized them to a structured exercise program for 3 years versus a usual care control. And we prevented death. Let's be very specific. We prevented death with exercise in those patients. And there was relevance for other cancers as well. It turns out that the prevention of second primary cancers was 50% as well from doing the exercise program. So, for example, breast cancer was wildly less common in the exercise group than in the control group in the 8 years of follow-up that they had. So that's the first randomized controlled trial evidence. We have oceans of observational studies showing something very similar. And so if people are interested in those kinds of papers, I would point you to Christine Friedenreich. She is the queen of the meta-analysis on this topic. I think her most recent publication on this topic was from either 20 or 22, and shows quite compellingly that not only is there about a 10 to 15% reduction in the likelihood of incident cancer as a result of being more physically active and meeting the physical activity guidelines, that I believe Jody was the one that presented those guidelines. But in addition, there's anywhere from 30 to 50% reduction of death from cancer after a cancer diagnosis for breast, prostate, and colon cancers from the observational literature. And again, we now have that randomized controlled trial evidence. So just to underscore this, understand that all of the chemotherapy drugs that are used to treat cancer cannot be approved by the FDA until there is randomized controlled trial evidence. That is the highest standard of evidence. So if the challenge trial was being published showing the benefit for a drug, it would be approved by the FDA, and it would actually be considered malpractice not to be using it if you can't find something that is better than this drug of exercise. But because it's not a drug, it's more complicated for us to implement.
I would add to that, there are also various studies, prospective trials that have looked at the consequence of disease, longevity without disease, so progression-free survival, right? Somebody has cancer, cancer is treated, we temporize the disease, and exercise has been found in some of these trials to help to prevent or increase the time before that disease returns. And then there is a wide body of evidence that suggests that interventions with exercise and rehabilitation reduce the toxicity related to side effects, help to mitigate long-term and late effects, and the functional sequelae associated with those. So yes, their challenges was groundbreaking because of the overall survival benefit, right? Like Katie said, people did not die who exercised more, and that is critical. But there are many benefits to exercise, including reducing those toxic symptoms, reducing the level and severity of toxicity, helping to optimize function. And I don't want to lose sight of Rob's comment. Have any of you just encouraged walking? It's free. Yes, I would say that should be a baseline, right? Everyone needs something, like I said. That's a great starting place, is to engage around walking. But, even again, equity and access, right? How do we promote health equity? Some individuals don't live in an environment where they feel safe to go outside and walk, or are in a community where they can't go out and walk. And so how do we encourage more movement based on the individual context? So I would say that would be a baseline for everyone, simple, easy. What else can I encourage them to do, maybe in the environment, in the context that they're in?
Absolutely. This one, I think probably Jody and Karen would love to hear from you specifically. Is there any evidence or research, or have you seen any success in patients with lymphedema related to vibration plates and rebounders?
I haven't read up that much on the vibration plates, I'll be honest, but there's certainly lots of research Catherine can attest to on exercise and lymphedema. She could talk about the PAL trial. I would be way behind her on that because she's the one that did it, but wonderful evidence on exercise and decreasing lymphedema. I mean, it's surprising looking back that they used to tell people not to do anything, for life. And now we know that, exercising regularly. Catherine can say the statistics better than me. I think there's a 70% reduction in the development of lymphedema in people that exercised versus those that didn't. So it's certainly a good reason to keep moving.
I would add in the force plates, there is some really compelling research ongoing both at MD Anderson and Indiana on peripheral neuropathy and force plates that's looking good, but I think we're gonna we're probably 6 to 12 months out from having those publications and moving that into, and the question that I've had, because I'm all about implementation these days, is okay, great. Well, you do this on a force plate that costs $3,000. I'm pretty sure I'm not shipping a force plate to Rob's house in Alaska for $3,000. So, and where is he traveling to get this thing? So I think that, you can buy little force plates that are, $150, but do they do anything? So we have, we're going to have some nice evidence. I think the evidence is going to come back positive. Everybody is nodding a lot when they talk about it, but implementation is not yet quite clear to me. I don't know, like, do Revital centers have force plates? No. Yeah, exactly.
We do not as well. So I just concur with what Jody and Dr. Swain said. Exercise for sure, but I really can't speak to a vibratory plate.
I know Dr. Stout mentioned this in her presentation, but we did have a question about, are there cancer-specific exercise apps that you guys really recommend that are kind of your go-tos?
Apps. Okay. Well, I have a conflict of interest, and I'll tell you about it anyway, as long as I admit to the conflict, right? So there's a beautiful set of videos intended for the oncology population at a website called My Victory. I bought My Victory as a company about a year ago. My intention is to make it free. I'm having technical difficulties trying to figure out how to get it out from the firewall that it's behind right now. But for $5 a month, you can have access to 3,000 videos. There's also Anna Schwartz has developed a beautiful app called Cancer Exercise. She was giving it out for free. And what she found was that, it was difficult to keep it up. So she put a little firewall on it and asked people for a little money. And then people felt like they couldn't afford it. So she's made it free again. It is on both the Apple and Android markets. And I highly, highly recommend it. The other online source that I'm really crazy about for women's cancers is called 2 Unstoppable, the number 2 and the word unstoppable.org. They do an outstanding job of leading classes, including specifically for metastatic breast cancer patients. I believe there's a small fee now. I think they have not been able to sustain their programming without a small fee. I should say there is a registry. If you go to movingthroughcancer.org, there is a registry of about 2,300 programs across the United States. It has the Exceeds survey at the front, so that if you should be going to a physical therapist or an oncology rehabilitation professional, it will guide you to oncology rehabilitation professionals near you. About 2/3 of the programming in the US is exercise oncology focused, and then about 1/3, and all of Revital is loaded in there, is oncology rehabilitation. So we're constantly trying to update that registry so that people can have easy access. And we're eager for there to be low cost or no cost options for people, because of the moment that we find ourselves in. We eventually are going to have to figure out how to get this paid for.
I am throwing all of this into the chat, Katie. I threw the link to the Exceeds survey on the exercise Moving Through Cancer site. I have someone was asking about Christine Friedenreich. I put her name in there, the Cancer Exercise app, 2 Unstoppable, Mapletree, Moving Through Cancer. So I'm just plugging them into the chat for folks as you all are talking about these great resources.
Yeah. And if anybody wants to help me figure out how to get My Victory out from behind that paywall. Oh, not my strength.
Anybody else have any that weren't mentioned that you wanted to throw out there?
Oh, there's Be Fit, Be Well from the University of Colorado, Anschutz. I don't know whether it's free. I just don't. But
Um,
I think it's the letter B, fit, and the letter B, well. If you were to do a search for it, maybe Nicole can find that, put it in the chat.
I will be looking for that. I know this
They
is
do a nice job online.
Okay.
Group classes.
I will also just plug the ACSM Exercises Medicine Moving Through Cancer work, Katie, that you initiated and has grown with the number of resources, both for healthcare professionals and for patients that are available on that website. So really nice, clean, simple to understand, simple to read, single page graphics that express where there is evidence for and what the type of evidence is for resistive training or aerobic conditioning. Really nice things you can print out, laminate maybe, and have them in your clinics or have as a guide for patients or even for healthcare professionals. So I'm a big advocate of educating the healthcare workforce. I think we need not only to have an increase in the number of exercise professionals, the number of physical occupational therapists and rehab professionals, but also much more broadly, we need recognition and understanding by the medical providers who see these patients, not just in cancer, not just in breast cancer and in cancer, but also as they move through their lifespan, primary care, onco-primary care, which is emerging. How do we keep those folks involved and informed about exercise? I will share with you that the American Cancer Society has entered a new partnership with the Health and Fitness Association. We are thrilled that we will be doing an RFA that's coming out soon for small grants to exercise programs around the country. They will be required by the grant to train a minimum number of their exercise professionals in their facility. They will also participate in facilitated sessions with a subject matter expert to help them really develop a program for an exercise oncology program, either for their fitness facility members or more broadly to engage with their local health systems and other local community partners to really build that capacity in the workforce and in the programming available. So HFA is the trade association that represents many of the larger commercial fitness centers and clubs around the country. So your Crunch Fitness, your Planet Fitness, they are all members and they will be eligible to apply for and receive these grants and facilitated engagement to help them create more exercise oncology programs.
Moving on to our next question, and I'm trying to categorize these, but as they come in, we're just gonna go to them. So if we ping pong around, we had an attendee ask, are there resources out there for childhood cancer survivors who are years out of treatment that can help prevent long-term effects, such as bone loss due to high-dose steroids or cardiac issues?
Yeah, these programs are not as well developed, in part because of the numbers game. The good news is there are fewer childhood cancer survivors than there are adult. The bad news is that the long-term effects are very meaningful. I would say that many, if not most, children's hospitals that have a focus on oncology have an oncology rehabilitation program and likely have physical activity programs for their survivors as well. So I think going through those hospitals is the first pass. I am unaware of anything in the registry that we developed that was specific to childhood cancer. I heard about one in California that popped up that was just, a local charity that was interested in physical activity for childhood cancer survivors. The challenge with that, of course, is that if that's a local charity, they're going to serve 25 people. There's just going to be a small number. So it's an ongoing challenge. Does anybody have any other ideas?
Yeah, I appreciate that. I think we have a lot of evidence that characterizes the problems in that AYA survivor population, and a robust body of evidence that suggests, longitudinally that these problems occur late, they impact function negatively. We are, in my opinion, just starting to see evidence that specifically starts to structure exercise for those cardiometabolic health needs, for those bone health needs. Because the exercise prescription, we can say weight bearing exercise, resistive strength training for the purposes of bone health. But what are the nuances and how we apply that to an individual who's, 15 years out from treatment, who's in their 30s, as opposed to someone who is in their 60s or 70s? What are the differences? And we need that evidence. And I think that is a space that we will see continued development. But we need that focused evidence for the interventions to be tailored in that population. That being said, I'll go back to Rob's comment, right? Walking, cardiometabolic health, bone health, lean mass loss. Those are common late effects that we see physically. Those manifestations, they're the evidence for activity, exercise, movement to help to mitigate strength training, to help to mitigate those consequences. But again, to go to the level of a specific exercise prescription is the evidence, I would say, I agree, is just not there yet. And I see my friend Scott Capoza in the chat. Hi, Scott. Thanks for your comment. I know Lynn Tanner is a physical therapist who is working in the pediatric space. So she says he's sharing that she's working on an app for childhood cancer exercise. Scott is a physical therapist who is also an oncology rehabilitation specialist at Yale, Sumilo, and in the Northeast part of the United States, and is a tremendous resource and advocate in the AYA space. I have to really just encourage us when we say PEDS AYA, we kind of blend all of that together. And even with AYA, we're talking about 15 to 39-year-olds. And so, the exercise prescription for someone who's 16 or 17 years old likely looks very different than someone who is 28 or even 38. So, really thinking about life phases, the motivational factors, buy-in, those social determinants also that occur need to really come alongside how we engage these populations in exercise and activity. I mean, if you want to say there's a population where there's not a one size fits all, it's this lump of what we call AYA cancers. And I'm hopeful that there's some work coming up in the near future that will begin to, make those differentiations a little bit more robust from the survivorship lens, because I think it's critical.
Thank you so much for that. Our next question, I have some patients with metastatic cancer who struggle with side effects that can be limiting. Oh my goodness. For example, diarrhea, nausea, fatigue, and they are also trying to keep up with activity, but it's challenging. Do you have any recommendations to help these manage some amount of activity that is realistic?
I think it's kind of like what we've said all along. You got to meet them where they're at. What can you do right now, and how can we incorporate it? And I think most importantly, as a physical therapist, sometimes you go in to work with a patient, you have your own ideas of, oh, I want them to do X, Y, and Z. But I think the most important thing, I think hopefully everybody will hear today, is it's got to be what the patient's goals are. Maybe my idea is I want them to be out there walking 10 minutes, and their idea is I want to be able to walk up the bleachers and sit at my son's basketball game. So you've got to really get to know your patients and get to know what motivates them, what's going to make them have a good quality of life. And that's how you got to reframe things, because it's always amazing to me in the clinic when I come up with ideas and somebody maybe is against it. But if I let my patient come up with the ideas, all of a sudden we go full steam ahead. Because if I'm really working towards my goal, then they're not really on board. And if we're working towards their goal, or even if I just say, okay, and this is very applicable to the patient I said is doing 2 days a week or 2 times a week, 5 minutes. I said, but what do you think you could do? And that patient came up with that. And I'm like, all right, that's where we're going to start. And I guarantee that person will do that because it was their idea. and I've got to just move with them there.
Completely agree. And I think sometimes I wonder if maybe we aren't one of the first people to ask them what they want to do, or what their goal is. And so that helps empower them even a little bit more. So if we can engage them and find what they want to do and what's meaningful for them.
Yep,
Also,
communication's the key.
yeah, I'll also maybe go to the other end of the spectrum, especially with that question when with a robust profile of toxicity and side effect. There are times when we have to say, yeah, today's a good day to do nothing, and that's okay. That doesn't mean that you've fallen off of the wagon and you can't continue your exercise program. That's okay, right? And this is where we walk alongside them and say, yes, but give yourself a break, give yourself some grace, step back for a day to get through that nadir, that high toxicity time period, and then let's talk about how you ramp back up. And then, there are some individuals that we have to pull the reins on a little bit and say, overloading is problematic for excessive fatigue or for bone lesion. So really thinking about, again, the tailored approach here is really an important piece of it. So the one-on-one engagement with an exercise professional, with a physical therapist, giving that guidance, and really, we're part cheerleaders too. I think Karen and Jody would agree with that. We are a little bit of a cheerleader for the individuals that we work with, because sometimes they just, I've got 2 or 3 days and now I'm down on myself. Oh, I gave up on the exercise program. But we can help give them that guidance that it's okay.
Well, and definitely, I think when you're working with somebody, especially going through active treatment or going through a lot of those side effects, having 2 or 3 different exercise programs is key. So I have a person I can think of right now I'm working with, and when she's around day 4 to 8 after her chemotherapy, she's feeling pretty not great. And so we have an exercise program. Okay, on those days, this is what you're going to do. But when we hit about day 8 or 9 and you're feeling better, this is what we're going to do. So they still have that direction because, and I can say myself, when I have an injury, an orthopedic injury, anything, it's hard to direct yourself on care. So it's nice when somebody else is giving you a little direction, a little permission of, okay, we're not going to do 0 on these days. We're going to do something, but it might just be stretches on these 4 or 5 days. But we will get back to that high level. We will. And we're going to do that around day 8 when you're feeling better. So it's just having that education and looking ahead, looking ahead through this cycle. We know we're going to have these days and this is what we're going to do. But on these days, we're going to do more fun things that you really want to get back to.
I love that. And Rob shared with us, I've been there dealing with the side effects. Then I sat on the floor or chair and would practice standing up or practice getting myself off the floor a couple of times at a time. So really just moving, just not being still. The next question we have is about prehab. This person said, I find that prehab is quite difficult to establish given how fast things move once a diagnosis occurs. Do you have any thoughts on this that you could share?
They're spot on. It can be very difficult. I think we've had to really look at it disease line by disease line and figure out what's the best integration point for that particular disease line. And it might even be different within the disease line. Some are going to have a very short window before surgery, perhaps, and others may be having some neoadjuvant chemotherapy, and we can be more involved during that time. So I think the biggest thing for us for a lot of our initiatives is we need to be at the table, we need to be talking with the teams, and we need to figure out that right moment per disease line. So I don't, at least for us, I haven't found the magic bullet that says this is the time and this is how we do it.
I definitely think the sooner the better is helpful because, think about what we're doing in that prehab setting. We're optimizing them for the next step. It's very indifferent than impairment-based therapy where somebody has an ankle sprain, we come in, we treat them, they go home. This is different. We're getting them ready for what we know is probably going to be a dip. So, sooner is always better if we can. But even getting someone 2 days before surgery gives us the time to get those baseline measurements and at least get some education on what they can do in that 2-week period from maybe surgery till they see us again. Because most people, if they don't know what to do, will do nothing at all. And that's not good for any, healing at all.
I think this is the perfect place to think about how do you integrate into the oncology workflow. The refer to PT is not going to work here, right? It can take them a week to get an appointment with you, and now you've lost all of that time. So these embedded workflows, these embedded clinical pathways, the evidence around prehab is not just exercise, right? So we're part of an ecosystem there, which is the ERAS protocols that you see, enhanced recovery after surgery, is what we see as the standard for colorectal prehab. That's nutrition optimization, it's stress management, smoking cessation, exercise. So we're part of that cluster. So those are the places where, how do we integrate that? Is it the thoracic surgery line? Is it the GI surgery line? Because if that's the first stop, that's where we need to think about intersecting with the patient workflow. I'll also share with you, we are very close to completion on an ASCO mask guideline for prehabilitation. It's taken us a while because of these challenges across different disease lines and disease types. And so I think, to your point, Karen and Jody, the type of cancer matters, where and when and how we do prehab and get those programs integrated. But we expect to see that guideline hopefully published with ASCO and MASC. MASC is the multinational supportive care in cancer care, MASCC, Multinational Association for Supportive Care in Cancer, with this collaborative guideline that will be coming forward. I think that will also help to catalyze more of our cancer centers looking at this and saying, how do we do it? And that's the clinical implementation and embedded service line approach.
I love that. I think that's so valuable. Thank you all for sharing. Our next question, someone is looking for the panel to walk through a patient process from functional assessment, kind of who does this? Does the provider take the assessment prior to referrals, to exercise rehab? Who works this area? Is PT part of the exercise rehab, or is PT a separate part of the process for more needed therapy? And Nicole, I know you just kind of talked a little bit about this, but would love to kind of hear, the full process of how this is integrated.
Yeah, I will say it depends. I would say if you have seen one implemented program, you've seen one. There's no right or wrong. There are ways that it has been done differently in different centers. I know Dr. Schmitz can speak to this from her perspective. I can share what I've seen in other centers. Sometimes it is right now. Our physicians in oncology rely heavily, you may be familiar with these performance scales, the Eastern Cooperative Oncology Group, and ECOG score, which tells us about sort of a subjective physician guided, well, this patient kind of looks like they're independent. So they score them, a scale from 0 to 5. 0 is optimal, 5 is dead. So, that's a performance scale that they're comfortable with. Karnofsky is another, 0 to 100. It goes the other way, like a percent scale. 100 is good. Is that sufficient if somebody does a Karnofsky or an ECOG? I would say if that's what your providers are comfortable with, it's a great starting place. There are other more sophisticated performance batteries that can be done. Some of that can be a questionnaire to screen. Are you active? Do you want to be more active? And then you can get into more detailed and robust physical performance, sit to stand tests, walking tests, step up, step down tests, arm curl tests, grip strength tests. I think you have to look at what is being done in your center and what is capable of being done with the resources and workflow that you have. So starting maybe with where you're at and thinking about, okay, so if we use an ECOG scale or a Karnofsky, maybe that's not ideal, but what's happening to the individuals who are falling at that 3 level on an ECOG, or the 70 below 80 on a Karnofsky? Are we even getting them? Are we identifying that there's a problem? Are we getting them resources? And if the answer is no, you've got a starting place right there. If you have the resources to integrate or implement, bring in an exercise professional, bring in a physical therapist. You can also use, there's some really good patient reported outcomes measures, the Cancer Promise tools, the function, the Cancer Promise Brief 3D has predictive validity. We can look at that change over time. It's a patient reported tool. Patients will tell you everything you need to know if you ask the right questions. So I'll just sort of start with that high level and then see if others have comments on that.
So I'm vice chair of the standards committee for the National Accreditation Program for Breast Centers. And I also sit on the accreditation committee for COC. And what I've been witness to in the conversations in those settings is rejection of objective physical function tests because they don't know who's going to do it. They don't know. They worry about how much time it's going to take. The resources are not available. Most community oncology settings, the people who are on the calls who are from those settings say, we don't have physical therapists in our offices. We're referring out to physical therapy. So the idea of a physical therapist or an exercise professional coming in to do those measures, 85% of cancer care is delivered in the community, not in academic health centers. And so the idea of doing objective testing, I think, is a best practice, is a gold standard, something that I certainly would expect at the James. Something that I would expect at MD Anderson or at Hillman. But for the average center, what I was able to get them to agree to in a new standard for NAPBC that should be coming out in 2027 is a functional assessment that for the lower body is indeed the ECOG or the Karnofsky, but they have to do something for the upper body. There has to be either an objective test, this is for breast cancer, or they have to do the DASH or the Penn Shoulder Score, or something that will help us to know what's happening with the upper body. And there was agreement, there was understanding that ECOG and Karnofsky don't tell you anything about the upper body, and that's a huge issue in the population of breast cancer. And in the setting of sort of all cancers for the COC, absolute rejection of any objective testing whatsoever for any standard that would help us to know who we're triaging people to, whether we're sending them to PT or to exercise. They're willing to endorse a short screening survey that's based on exceeds. That's about as far as we can get them to go. So I think that the standard of care is one answer to this person's question. The standard of care is there's nothing currently in most places. What we're trying to get the standard of care to be is some kind of survey. And I think we can get there for accredited hospitals. The gold standard best practice is to do objective physical function testing. That's what I see.
Thank you.
And I think you also have the challenge of our oncologists are not exercise professionals and they are not physical therapists. And so when you say a 20-second sit to stand test, what the heck? Who's going to do that? We don't have time. We don't have, nobody knows. And then what do I do with that information? If I find that there's a problem and I don't have the resources to refer someone or to get them to an exercise professional, I don't want to open the can of worms if I can't manage what comes out of the can once it's open. So I agree. Some of the things that we have done when I was at WVU Medicine recently, we leveraged our distress thermometer, which is already embedded into our clinical workflows. Our nurses and specialty care nurses and APPs know exactly when they do distress screening. They characterize the problems, and then we said, well, what's happening? it's interesting. It depends on what the nurse decides they have time to do that day or is able to do or knows what to do. So we automated through our electronic health record. If someone selected a distress score greater than 4, which is an NCCN guideline concordant score, and they ticked the boxes around mobility, physical function, swallowing, those would trigger an automated in-basket to a rehabilitation pool where that case would be reviewed, and in some instances they would call the patient and have conversation with them. You saw Dr. Smith the other day, and you said your fatigue was escalating and was an 8, and you're having problems with fatigue and moving around in your home. What are the things that are going on? Tell me about that. And sometimes what we published, this utility score, we identified about a third of those people went, I'm good. Everything's fine. I don't really need anything. I actually forgot that I, said that, and I'm good. About a third of those people said, I would love some information. I would love to talk with someone further to understand what we can do. And about a third of those folks were like, yes, I've had a fall, or, it's an escalating problem. I'm weaker. And those were folks that we needed to get into to the rehab service line. And so that added step in the process, we felt, it decreased the burden on the physicians going back to the doctor and them having to decide, okay, what do I do with this situation with this person who has these complaints? And it worked so well that we actually scaled that workflow to provider pools for social work, for spiritual counseling, all based on the distress thermometer. Was that perfect? It was not, but it was great because it was already something everyone was familiar with, like an ECOG or a Karnofsky. When the problem boxes got ticked, it was an automated process that we set up in the electronic health record. Sexual health, it went to our sexual health team. We have a nurse, we have an APP, male and female, to review these cases, look at what's going on, and give the patient a call. So that behavior management, that navigation strategy, principal illness navigation, was how we were able to get those services covered. So it was really about operating within the system that you are in. Huntsman Cancer Institute in Utah, for example, has embedded a tool called the AMPACT, the acute mobility in post-acute care, and they use that, again, questionnaire to the patient. It gives them a general idea of their mobility, and they have created a triage approach based on that. Is it perfect? No, but it's asking the question, it's opening the door, and it's potentially identifying, when there are emerging or changing issues. So I think, to Dr. Schmidt's point, start simple, work with what you have. There's nothing worse than walking into your oncologist and saying, well, here's the 10-page questionnaire we want to give to everybody, and their head explodes. And then we're asking them to do more, right? They need the easy button. So how do we deliver that?
I would add to that too. I think that one thing I found really effective is talking to a doctor and finding out, what impairments do you usually see with your patients? And, if we could help with that, would that be beneficial? And then building it into their order set. So if, maybe a breast line says, well, I want all of my mastectomy patients and lumpectomy with lymph node biopsies to be sent. Let's put that on the surgical checklist. So it's automatically sent. And it's not, well, when I remember, those people are going to get that service, and when I forget, those people are not. And then we're kind of catching things ahead of time. And then that doesn't take the physician any longer. It's just built in, and it's their decision on, well, I want these patients to be seen. Okay, let's make it a process so it's easy for you guys, and it happens every time, so nobody gets, lost in the cracks.
Thank you so much. Can't believe we're running out of time. I'm so bummed. We have a few more questions I'd love to get to before we get final thoughts. The next question from an attendee: what are your thoughts on the pathological fractures in association with bone mets and their mobility exercises and limitations due to pain?
Okay, I'm gonna open here with something that I'm hoping Nicole can search and find in the chat.
I'm already on.
Okay. Kristen Campbell from the University of British Columbia has done yeoman's work in organizing experts internationally to understand how we appropriately triage and prescribe and carry out exercise with individuals who have bone metastases, including those that have lytic lesions and those that do not. So there is an entire website around this that is, Chris is really good at making these gorgeous infographics that help people to understand, and you can apply them in your clinic. The full paper is available there too, for the guidelines that I believe are published in JCO Oncology Practice. And the basic idea is that there should be a lot more scrutiny of these patients with metastatic disease in bones prior to them starting their exercise program, and then a lot more monitoring as well. And so, we wouldn't go so far as to say, no, this can't be done by an exercise professional, but it needs to be done by somebody who's either an oncology rehabilitation professional or somebody with advanced training as an exercise oncology professional. So that's kind of where we go. We actually did do a thought exercise back when I was at Penn State about trying to understand the likelihood of a fracture with exercise for most of the types of bone metastases that exist within cancer patients, and with the exception of the very lytic lesions from the multiple myeloma patients, it's actually, strangely, at least in theory, fairly unlikely that there's going to be a fracture as a result of being more physically active, because of the nature of how exercise loads the bones, as opposed to where the bone lesions typically exist within the bone. So that's hopeful, but it's theoretical.
Anybody else have anything to add?
Well, I'll just add, I know that the better we work with our physicians and the better we have the confidence that they're giving us a good assessment of what those bones look like, I think we feel more comfortable than as we prescribe or work with those patients. Yeah, I'll stop there.
I'm putting a couple things in the chat, which is the Bone Metastasis and Exercise Hub. Some of the references. I think the bottom line is the answer isn't no or don't do for most patients, but there's an adaptation, and we need to very much, like Karen said, I can read a report, but I don't have X-ray vision. So I don't know, I need to understand the nature of the lesion, the location. Is it a weight-bearing bone? Is it going to take torsional forces? And that's what the Merrill classification system can help us identify, because there are different levels of risk that have been derived from that classification system. Again, is it perfect? I think it's a guide. I would say, let that be a guide for assessing, assessing risk.
Well, we have one last lightning round to close things out, and I just want to thank you all again. I'm just a comms girl, so being on a panel and talking with you guys and hearing from you is such a privilege and an honor. So thank you so much. For our lightning round, if you had to name one practice change that would most improve patient outcomes through movement, what would it be? Jody, we'll start with you.
I was just going to say, I would definitely say looking at things through a prospective surveillance lens as opposed to an impairment-based lens, because I use my ankle fracture example again. Usually you treat a patient, they're better, they go on. But when people are going through a cancer treatment, we see them in prehab, they're looking great. They're going to have that dip during surgery. They're going to get better. They may have another dip through radiation. So we've got to be able to surveil them throughout all of that. We have to anticipate what's coming. So that, I think, is the biggest change we need to see to be successful.
All right. Karen, you're next.
Me?
Yep.
Okay. I think we have to, well, along with what Jody said, we just have to have that system approach. Nicole mentioned it. It's been mentioned several times, but get them at the very beginning of their diagnosis and then not make it so hard for us to be included all the way down the line. That it has to just be more automatic.
Okay. Dr. Schmitz?
So I'm really, really stuck these days on the idea of return on investment. I think we have to establish the economic case for exercise and oncology rehabilitation. And I think until we do that, I think we'll continue to have the kinds of problems that we have making it standard of care.
And Dr. Stout, round us out.
Yeah, I love prospective surveillance. You know, it's my heart and soul and baby. But if we take that to a larger level, I would say it's about whole person care using that model. Rather than looking at an impairment, I am hard pressed to find a patient who has upper extremity lymphedema that also doesn't have some mobility issues with their shoulder, some strength issues in that extremity. And, you know, along with that, oh, they were treated for cancer. So there's some fatigue and maybe some emerging cardiometabolic issues. We really have to be able to assess and engage in exercise and rehab with the whole patient. And unfortunately, sometimes our payment system today allows us to choose one impairment and say, oh, it's a lymphedema patient. We've got to get out of that from the perspective of how we assess and how we provide care. Whole person strategies are what we need.
Well, thank you all again so much. You four women are incredible. And we've just gotten such positive feedback. I didn't have to use one of our pre-written questions because the audience was so engaged, and that's a testament to you four. So thank you. We are very pleased to announce that our upcoming forum sessions will be focused on a few additional incredible topics. In July, we will focus on caregiver support. In September, tobacco cessation, and in November, mental health and cancer care. These are critical topics, so we hope that you'll join us for each of these sessions. We are also pleased to share that this program and all of our previous programs will be available on YouTube. CMEs are only available for the live event, but please share what you have heard here today with your colleagues or check out some of the sessions that you might have missed. The CME certificate will be sent out in 2 weeks. Once you've completed, and that'll come after you've completed the post-event survey. The survey will pop up at the close of today's session, and you will also receive a post-event email with the recording and the survey link in case you missed it this morning. Thank you again for joining us today and for your commitment to fight for a world without cancer. We really appreciate you being here.